My name is Marc Baertsch, and I'm a physician at the Myeloma Center at the University Hospital in Heidelberg. And it's my pleasure to present here on the phase 3 multicenter trial ReLApsE of the German-speaking myeloma multicenter group. This trial investigated the role of salvage autologous transplants in relapsed multiple myeloma. So the ReLApsE trial is the first and still the only randomized controlled trial of a salvage high-dose chemotherapy and autologous stem cell transplantation approach versus continuous novel agent treatment. The trial ran in 16 sites across Germany, recruited 282 patients in a time frame from roughly 2010 to 2016, and the primary analysis was published in 2021 with a median follow-up of 37 months and based on 66% of all possible PFS events and 29% of all possible OS events. At the time, no survival benefit had been observed in the primary ITT analysis. However, landmark analyses performed from the time of salvage transplantation due to a significant dropout rate before the transplant step. Those landmark analyses had suggested a benefit of the salvage transplant. What I'm presenting here is the long-term follow-up analysis of the trial with a median follow-up of now 99 months or roughly 8 years. And this is now based on 86% and 63% of all PFS and OS events respectively. So the ReLApsE trial randomized patients between two arms. Arm A, or the control arm, consisted of standard Lendex, given at the dosage levels indicated on the right side, lenalidomide 25 milligrams on days 1 to 21, dexamethasone 40 milligrams weekly within 4-week cycles. And this was given until progressive disease in Arm A. In Arm B, patients received, Arm B or the transplant arm, I have to say, patients received 3 RD or Lendex reinduction cycles, then went on to high-dose chemotherapy with melphalan at the 200 milligram per meter squared dose level, then received the autologous stem cell transplant, then received lenalidomide maintenance until progressive disease, lenalidomide maintenance at the 10 milligram daily dose level. So major inclusion criteria were first to third relapse of multiple myeloma and age up to 75 years, and time to progression of at least 12 months in case a frontline transplant had been performed. Exclusion criteria were prior salvage transplant or lenalidomide refractoriness. This resulted in randomization of an overall balanced trial population with a median age of around 62 years, performance scores of 0 or 1 in virtually all patients. ISS stage 1 was present in 60% of patients and stage 2 in roughly 30% of patients. High-risk cytogenetic lesions were observed in 32% of patients in Arm A and 43% of patients in Arm B, with the major drivers of poor prognosis, deletion 17p and amplification 1q, being present at slightly over 10% in both trial arms equally. The median interval from diagnosis to randomization was roughly 4 years in both arms, and 94% of patients had received only 1 prior line of therapy. The same percentage had received a frontline transplant. And in terms of therapeutic agents used during prior treatment, I want to highlight that roughly 10% of patients in both arms had received prior lenalidomide. However, none of these patients were refractory as per the exclusion criteria. So this is the long-term follow-up analysis of survival. And as you can immediately see, there is no survival benefit associated with any treatment arm, neither for PFS nor for overall survival. Median PFS in Arm A was 19.3 months and in Arm B 20.5 months with a hazard ratio of close to 1. And median overall survival was close to 63 months in Arm A and 67 months in Arm B with a hazard ratio of close to 0.9. So as mentioned earlier, there was a significant dropout rate in the transplant arm before the transplant step. And this resulted in 29% of patients not actually receiving their planned salvage transplant. This was mainly due to early progressive disease in 17 patients, adverse events in 8 patients, and withdrawal of consent in 7 patients. So out of 139 patients initially randomized to the transplant arm, 98 patients actually received their salvage transplant. To better assess the treatment effect associated with the salvage transplant while not introducing undue bias, together with our biostatisticians, we chose to perform landmark analyses from the time point of the salvage high-dose chemotherapy in the transplant arm and the corresponding treatment phase in the control arm, which was the beginning of the 5th cycle of Lemdex. Also in these landmark analyses, now with prolonged follow-up, we do not see any benefit of the transplant arm in terms of progression-free survival or overall survival. Median progression-free survival now from the time of transplant was 20.3 months in arm A and 23 months in arm B, and median overall survival from transplant was 66 months and 76 months, respectively. Hazard ratios for PFS close to 0.9 and for OS close to 0.8. Also in multivariate analysis, including established risk factors in the myeloma space, we did not see any effect of the treatment arm, neither on PFS nor on overall survival, while significant factors for both PFS and overall survival were high-risk cytogenetic lesions, baseline LDH elevation, or absence of frontline transplant, although the latter was a very small subgroup. Factors prognostic for progression-free survival were prior lines of therapy and age, while ISS stage 3 versus 1 was associated with inferior overall survival. The absence of a PFS benefit associated with the transplant arm was consistent across key disease subgroups, and this is shown here for subgroups according to International Staging System, RISS, TTP1, or time to progression after a frontline transplant, cytogenetic risk status, age, renal function, baseline LDH levels, frontline single versus tandem transplant, the number of prior lines of treatment, and also whether prior maintenance treatment had been given or not. And without going into too much detail, the same is true for overall survival, where we do not see any significant effects in the aforementioned subgroups. So lastly, I want to highlight the role of TTP1, or time to progression after a frontline transplant, and its effect on subsequent treatment. As you can see here, the patients with the subgroup with the longest TTP1 of 48 months or more, that's the blue curve, does significantly better during subsequent treatment as compared to the subgroups with shorter TTP1, which is the orange and the black curves here. And this is true for the overall trial population, as well as for each trial arm independently. However, there is no predictive value in TTP1 as to whether a patient benefits from a transplant versus Lemdex. And this is highlighted here by the purple versus the light blue curve of patients in the longest TTP1 subgroup in arm B versus arm A, where the hazard ratio for this comparison is 1.0. And similarly for overall survival on the right side of the slide, we did not see any significant effect of the transplant arm in any of the subgroups according to TTP1. So summing up, the ReLApsE trial is still the only randomized controlled trial of a salvage high-dose chemotherapy and autologous stem cell transplant versus continuous novel agent-based treatment. We did not observe any significant PFS or overall survival benefit of a salvage transplant and lenalidomide maintenance versus standard Lemdex, neither in the primary analysis or on landmark analyses. TTP1 is a prognostic factor, but it is not predictive for a benefit from a salvage transplant versus Lemdex. And while this trial can obviously not answer all questions surrounding salvage transplants for myeloma, especially regarding the changes of the dynamic treatment landscape with a lot of novel or more modern agents having been approved during the recent years, still the ReLApsE trial does not support routine use of salvage transplants for relapsed or refractory multiple myeloma. With this, I would like to thank all patients that participated in the trial, thank their families, all the GMMG trial sites across Germany, the GMMG trial office in Heidelberg, our biostatisticians at the DKFC, and Hartmut Goldschmidt as the head of the GMMG. And thank you so much for listening.